My name is Jody Gutkin, and I will be your presenter for the topic Heat Beyond the Basics. I've been a physical therapist for 28 years and also involved in physical therapy education for over 20 years, and I look forward to discussing this topic with you today. What we're going to focus on during our course is heat, which is a traditional modality that we all utilized in the clinical setting. We're going to take a little bit different slant on it. We will review the typical physiologic effects, look at its influence on the soft tissues, and how the research is supporting the use of heating modalities. And then we will expand our conversation to some of the emerging uses of heat to manage different chronic conditions and also all the different over-the-counter delivery methods that are available. The rationale for this course is to have us step back and take a look at this modality from a little bit different perspective, and also look at the current research to see, does it align with our traditional expectations of what we're accomplishing with our heat, and then expand into some of the more innovative uses of heat that are on the horizon to manage different chronic conditions. So the use of more environmental heating and external systemic heating in order to influence the body's reaction and manage some different chronic conditions. Our goals and objectives are aligned with that. During our first hour, we will take a look at our physiologic effects and traditional heat applications. During our second hour, we will move into some of the over-counter options to utilize heat and also some specific impairments that we manage. And then in our third hour, we will look at heat stress, exercise performance, and chronic disease. Everything we're discussing today is based on current research. All of those references are included at the end of the course notes packet so that you can access that information if you want to read a little bit more about what we're discussing. As with any course that you attend, when you go back into the clinic to apply this information, you will do so in accordance with any federal, state, and professional regulations where you practice. You will notice that on several of the slides, there is this blue icon that says consider this. That's to let you know that those particular slides will be helpful when you go to take the course post-test later on today. As we look at utilizing heat as a modality, it's always fun to start with a little bit of a historical perspective. And this dates all the way back to the times of the Egyptians, where they utilized sun therapy. The Greeks used to dig out sand baths and have individuals with painful joints and edema go into them and cover them with the sand. When it would cool off, then they'd move them over to the next one. Hippocrates utilized steam baths in order to manage pain for the individuals, and it was described as to relax the skin and draw forth the corrupt humors. We've modernized this today for our traditional use of modalities: hot packs, paraffin, Fluido, whirlpool, diathermy, for our different heating modalities in the clinical setting. The physiologic effects that we learned way back in school still seem to be where the research is supporting us. We have our primary benefit is vasodilation, where we have that increase in capillary blood flow, bringing oxygen and nutrient-rich blood into the area, clearing of metabolic waste, altering cell membrane permeability. Combine that with an increased tissue temperature rise. This is going to contribute to deformation of collagen rich tissues in order to increase their elasticity. We have influences on metabolic rate when heat is applied, along with that tissue temperature rise, increasing cellular metabolism, increasing the rate and ability of hemoglobin to release that oxygen to contribute to the healing process. And then we also see that heat has benefits on nerve conduction, sedating those nerves to alter the pain threshold, and then also on our muscle spindle firing. The research is still with us on those basic physiologic benefits. Where we need to be specific is what rate of tissue temperature rise is needed in order to actually elicit those effects. And in the therapeutic community, this has been researched to see how much of a tissue temperature rise is necessary. Everything now that we look at is documented in degrees Celsius. So to give you a little bit of an idea, about 38 degrees Celsius is equal to approximately 100 degrees Fahrenheit. To give you a little bit of a mental conversion there. When we have a 1 degree Celsius tissue temperature rise, at that point, we're starting to see an increase in the metabolic rate of the tissues. As we progress to a more moderate heating with a 2 to 3 degrees Celsius tissue temperature rise, we're going to start to see not only a more significant increase in that metabolic effect and circulation, we're also starting to see alterations in nerve conduction, that those afferent fibers are influenced and analgesia is going to set in. Where we really want to be to maximize those heating benefits that we discussed is at a vigorous level of heating, and that is a 4 degree Celsius tissue temperature rise. This is where we're going to see a significant increase in metabolic rate and circulation. And at that point is when the changes begin related to having that modality that's been applied increase the tissue temperature significantly enough to influence those collagen rich fibers for improved viscoelastic properties. So that 4 degree Celsius rise is what we're shooting for in our application of our modalities. Another consideration when we look at not only getting the tissue temperature rise, but how long we need to sustain it, is an awareness of how the tissues respond to that increase in temperature. We all remember back in school that memorizing heating modalities, many of them are applied for about 15 to 30 minutes. And I remember when I was testing students on practicals and I require them to give a rationale for every modality and every parameter. The reason could not be because we do it 15 to 30 minutes. Nope, there's thought process behind that. And what we're considering is the rebound phenomena. That in about the first 5 minutes when a heating modality is applied, that heat is going to be absorbed faster than it is being dissipated through the local circulation. And then by about 9 minutes into the application of our heating modality, that temperature gradient between that maybe hot pack external and the local tissues is beginning to stabilize. And then we seem to reach more of a constant treatment intensity. And at that point, we're getting our maximum vasodilation, and we're looking at that occurring at approximately 20 to 30 minutes of our treatment intervention where we've sustained that. If the heating modality continues to be applied beyond that point, the body is going to recognize that there is too much of an increase in tissue temperature. It is going to react with protective vasoconstriction in order to avoid damage to the surrounding tissues. Problem is, it's now vasoconstricting the vessels, but if the heat is still being applied and supplied to the area, now the ability to dissipate that heat has been compromised, and this is when individuals are at that risk of burning. So this is what we're trying to avoid with the application of our modality. We want to stay in that therapeutic time range for our benefits. Depth of penetration is always a question with the modalities. In examining the different research that's out there, historically, we always considered that our superficial heating modalities reached about a 1 degree Celsius tissue temperature rise, about 3 centimeters down. But our deep heating modalities can achieve that 4 degree vigorous heating Celsius rise at about 3 centimeters down, so about that 1 inch. And those would be our diathermy, our ultrasound heating modalities. So, depending on the area that you're treating, maybe even with a more superficial modality, if it's on the hand, you are eliciting those higher tissue temperature rises at a depth. But if you're treating the area of the back, you may not be reaching that vigorous heating for all those desired physiologic effects. I did find a 2013 study that looked at hot pack application to the gastroc compared to a shortwave diathermy application. They used a probe implant in order to assess the tissue temperature rise every 5 minutes. And at a 1 centimeter depth, they did find that the shortwave diathermy did increase the tissue temperature greater than that hot pack. As we're applying modalities, we need to consider, is it safe to apply the desired modality to the individual? Even if it has the physiologic benefits that we want, is there any reason that it's contraindicated or precautions that we have to take while we are applying that modality? And we all remember memorizing those different lists. And I always think with contraindications and precautions, if we understand what's happening physiologically with the modality and we understand the different conditions or disease processes, we can make a clinical judgment. We don't just have to memorize a list of guidelines of precautions and contraindications. And that's important because as you look at the research, there's not a lot of consistency. There was one systematic review that I did find where they looked at all the different resources out there between 1992 and 2002 for contraindications and precautions for different modalities, including heat. And they pulled the textbooks and the research. And what they found is that a lot of the references just come from textbooks, and many of those textbooks did include research to make their claims as to those precautions contraindications list. And there seemed to be relative consistency on about 5 to 9 contraindications. Precautions, there seemed to be an array of somewhere between 20 to 32. And that's where that clinical judgment comes in. And often it was referenced that a lot of it was just in an abundance of caution. When we look at this list of contraindications and precautions, we know that applying superficial heat to acute trauma or bleeding is going to increase vasodilation and circulation, and that could be detrimental. Then we have cognitive impairment. Well, is it a contraindication or is it a precaution? And this is where that clinical reasoning has to come into play. Because when I see cognitive impairment, I'm not just considering that patient who maybe does have dementia or an inability to recognize if something is too hot to share that. But is the patient able to actually communicate that physically? Is there a language barrier? Is there some other barrier to them being able to let us know if something is too hot to avoid a potential complication for them? And also consider that we have some different considerations looking at how different medications are being delivered. More often now, we have transdermal and topical medications, topical analgesics that are applied that we don't want to combine with the application of heat. So we need to be aware of that. When we check our medication list for our patient, we need to know the mechanism of delivery for those medications because we don't want to treat over a topical or a transdermal with a heating modality. And cancer is always a consideration. When someone has cancer, is it a blanket contraindication? When we look at the research, there's many factors to consider with that. The Journal of Hospice and Palliative Medicine put out a classifications of rehabilitation for patients with cancer. And what they describe is that we have different stages. Individuals may be in a preventive stage where we're just trying to address functional decline, maybe restorative, where we are expecting them to make some gains, even though they do have cancer. Supportive, where we're just trying to improve that quality of life for them, improve their ability to perform different tasks and activities. And maybe there's going to be some progress, maybe not. And then we have the palliative stage, where the individual is nearing end of life. And depending on where someone is at in this, whether or not the use of a heating modality is appropriate, that risk benefit analysis needs to be discussed. Some considerations looking at a 2018 report from the Physical Agents and Modalities for Cancer Survivors. There was a discussion that any patient should really be screened for a history of cancer. Particularly with greater direct access, we need to consider adding standard screening questions for all of our patients. Are they having fever, chills, sweats, night pain, loss of weight, all of those kind of red flags that when put together potentially could mean that they have a new cancer, or if they did have a history of cancer, that the pain they're feeling now may not be musculoskeletal. Could it be a potential metastases? And we need to recognize that to refer appropriately, and so that the heating modality does not potentially increase that spread of the cancer. When someone has a stage 1 to 3 cancer, we don't want to treat directly over that area with the heating modality, because we could potentially increase the spread. Versus someone who is at a stage 4, at that point where they're receiving other care, radiation, chemotherapy, we need to make sure that when we're applying a heating modality for a palliative reason, that it's not being performed in an area of those adjuvant therapies, that we don't want to compromise that delivery with the application of our heating modality. Some of you might be involved in treating patients who have breast reconstruction or post mastectomy for breast cancer. And whether this is recent and we're treating them as that course of care for that original diagnosis, or it's years or decades later, it's important for us to remember that that region where they did have that mastectomy and potentially breast reconstruction surgery, sensation is typically different, that not all patients have full return of sensation into that area. And patient education has to come into play so that they're aware of this to avoid a potential risk of burning. For example, we need to consider to educate the patient, not just saying, oh, you're going to have decreased sensation. Do they realize that if they're just wrapped in a towel after they get out of the shower and they start blow drying their hair, well, that heat on that chest area could potentially cause a burn that they may not be feeling. Think about going out in the sun with greater exposure. It may not be perceived. Even using a warming blanket over this area, sensation may not fully be intact. There was a practice in England that treated women for breast reconstruction following mastectomy. And in 2016, they did a retrospective analysis because they were finding higher rates of burns in their patients. And they did recognize that it was to the point where several patients actually needed skin grafting to treat that burn. So it's important that we recognize not only in educating the patient for safety for the rest of their life, but also, if the patient does have a history of mastectomy and surgery, when we're now treating them for their shoulder or their cervical area, when we put maybe that hot pack over the region, is it resting too close to that area where they may not have sensation? Do we need to increase our toweling a little bit to ensure safety? When we look at that palliative care for patients, one consideration is that the use of heating modalities could decrease the use of different pain medications. That by providing pain relief, muscle relaxation through a heating modality, it may decrease the need for different medications that may allow the individual to be more engaged and have better moments at that end of life versus having all the side effects from those pain medications. There, of course, is the concern that there could be a spread of the cancer. And that's where that conversation has to come into play with the patient, the family, the doctor, and therapy to decide what is most appropriate and make sure that that is documented. As we look at other precautions, transdermal medications are becoming more common. This is where medications are applied using a patch, similar to this. So, when the individual has a patch applied to deliver their medications, this might be for lidocaine, or maybe it's a nicotine patch, different hormone therapies, birth control. The way that these are manufactured is this adhesive component. This is what controls the delivery rate of the medication. And this one's used, if you look at the reservoir, if I slide it down here, you can kind of still see that there's some medication left in it, even though it's already been used by the patient. And these are built with more of a reservoir of medication than what's actually needed to be delivered for the patient. So the intention is that there's a steady state drug release that's going to be absorbed through that outer layer of the skin, and then it's going to diffuse into those superficial capillaries for slow, controlled systemic distribution. Well, if we apply a hot pack over this, it's going to change that adhesive quality and can particularly change the delivery rate of the medication and its potential that we can increase the delivery of the medication to the patient and alter what they are receiving. So we want to make sure that whether a patient's applying heat at home or we're doing it in the clinic, that we're not doing so in a way that can alter that drug release rate. As we perform any intervention for our patients, we're always going to do it according to standards of practice. We don't want to harm our patients. And professional liability is a consideration. When you look at the application of modalities, and for that matter, any interventions performed in therapy, CNA and HPSO, those are the large insurances utilized by healthcare practitioners, particularly physical and occupational therapy. And they put out different reports looking at the different liability cases that have been litigated and paid out. The most common reasons for cases are improper management, improper physiologic performance of a biophysical agent, failure to supervise, and this is true for both PT and OT, improper management, failure to supervise. And when we look at this, a lot of this relates to the application of particularly thermal modalities, that we need to make sure we're supervising our patients appropriately and applying the intervention in a way that avoids harm. When we look at the different claims that do occur for burns, it is staggering to see what a high percentage of the claims that are paid out are related to burns. It's of course sad that there are any claims and any harm that comes to a patient, but for both PT and OT, the most common injuries sustained by patients in general are fractures due to inappropriate care. The second to that is going to be burns. And for both PT and OT, 18% of the claims that are paid out are because of burns. And when we look at that 18% of the claims, over half of them are due to a hot pack. And this is definitely preventable through our appropriate application. And what they found when they looked at patterns in the claims and the injuries that did happen, a recurring theme is that patients were not monitored appropriately when the heating modality was applied. That if they had a sensory deficit or some type of precaution, that it was not given the appropriate attention by the clinician to avoid injury. And I put this out there just as a reminder to us that when we're doing things that seem routine in the clinic, we still need to give it that same level of attention like we do with other maybe more complex interventions that we're applying. And one first step would be to inspect the area where we are going to be applying the modality. And we know this. We're going to look at the patient's skin. We do need to actually reveal that area, and something that we're going to look for that would be a red flag to us not to apply a heating modality in that area would be erythema ab igne. And this is what it looks like on the bottom left. We'll start here. Kind of looks like a reticulated brownish pattern, kind of like a netting or weaved pattern. And what this is a alteration of the vascular supply in the area. On the bottom left, this is someone, and you can almost see below the line that I'm drawing, a sharp edge delineation there. This is someone who was utilizing a water bottle over their abdomen for chronic pain, and they were utilizing it too frequently and left it on too long. What happens over time is that the vasculature becomes damaged in that area, that it is unable to dissipate the heat when it is exposed to prolonged heating. And in the center image here, we're looking at a punch biopsy of someone who had erythema ab igne on their back from overutilization of a heating pad. And what is noticed when they look at this is they find that the elasticity is lost in those blood vessels. This scanning magnification also shows infiltrates in the area, and that fragmentation damages the blood vessel and its ability to dissipate the heat. If it's only short term, this can be transient and reverse itself if the individual stops exposing that area to the heat. However, if they continue to do that, the damage is going to persist. If we're educating patients to utilize heating at home, we need to make sure that they avoid this. Other ways that this can occur is if someone, let's say, leaves their laptop sitting on their lap for too long, that the heat can't be dissipated. heaters, space heaters sitting in front of them, even heated car seats. If someone doesn't realize maybe they have decreased sensation and they're just not thinking that, oh, I'm applying heat, I may be damaging my vessels because I can't feel that it's getting too hot. Or they're just not following instructions, they're using it for too long, not realizing the consequences. The image on the right here, we're looking at a patient's dorsum of their foot and that anterior area of their tibia. This patient would present to the clinic intermittently, and they had this occurring bilaterally on the front of their legs. Clinicians are trying to figure out a pattern to it as well as the doctor. And what they found out is that this individual in the winter months would just sit in front of the fire and the erythema embignae would develop. And then in the warmer months, when she wasn't doing that, it would dissipate. So important for us to just inspect the skin to make sure when and where we want to apply our heating modalities for safety. Checking skin sensation is important to know that our patients can actually feel the heating modality. And this is always interesting if we were a live course to see everyone's faces. How often are you checking hot, cold, sharp, dull sensation? Is it assessed in every area where a heating modality is going to be applied? Is it reassessed if it may have changed over time for the patient, that individual with diabetes or a neurologic condition, or orthopedically, if they have a compressive neuropathy? Is sensation reassessed to see if it's now safe to apply that heating modality? All things that we need to be aware of in order to document appropriately and make sure that it is safe to apply that heating modality, that the patient can give us feedback. Are we educating our patient when that modality is on? How should it feel? What's too hot? And it may seem like common sense to us, but how often have you been maybe getting your hair done and they're rinsing it out and that temperature is just a little too hot and you think, oh, well, it's only going to be a couple minutes, or I can take it. Maybe it's just me. It's not too hot. Our patients go through the same thing. And we need to let them know what exactly they should be feeling, and that it's okay to tell us if it is too hot or it doesn't feel right. If you have the Velcro strap on holding the hot pack in place, for example, can they actually reach it to take it off? Have you told them they can? Do they have the dexterity to open up this Velcro? And they have some way to get the clinician's attention. In those litigation cases, it is noted that that failure to supervise, failure to assess and modify the treatment intervention for the patient is a concern. There was a case study that I read of a clinician treating a patient for a hand injury who did sustain a burn. Clinician recognized it right away, instructed the patient appropriately to seek medical care, coordinated with the physician, had great documentation all the way, had documented the skin inspection pre and post, documented the follow-up care that the patient was instructed to perform. When it did go to court, yes, the clinician had injured the patient, so it did not find in favor of the clinician. But because there was such good documentation that due diligence was happening after the injury was noted, that the award for the patient was less than it had been if the clinician didn't have all that documentation to say that they were taking appropriate action. When we look at applying a hot pack, layers of toweling we know need to be sufficient to control that heat transfer. How many layers do we use? Everybody memorized it, right? We're looking at 6 to 8 layers of quality toweling. What is that? How thick? That new hot pack cover is 2 to 3. Can you hold yours up in the clinic and be like, well, I can't quite see through the whole thing. That's not 2 to 3 anymore. And we know this happens. It just means maybe you need to add other layers. We need to be aware of this. Patients should not be laying on the hot pack because that compressive force of the weight lying on the hot pack, not only is it going to alter the conduction, it's going to dry that hot pack out more, kind of squeeze the water out of it or the moisture out of it. But those tissues are compressed. They can't dissipate the heat as well. So patients really shouldn't be lying on the hot packs. If we do need to have them lie on it, we better be documenting how we altered the intervention with skin inspection or adding more toweling and post-inspection to make sure that injury did not occur. And think about when you consider your layers of toweling, how hot is the hot pack that particular day or that time of day? And it sounds ridiculous, but I think you all know where I'm coming from. If that hot pack has been sitting in the unit overnight versus you're at a busy clinic day and now it's only been put back in for a certain amount of time, what's your rotation schedule with those little colored tabs? I did look at a study that assessed the rewarming of hot packs and how long does it take for it to come back up to temperature. And it found somewhere between 20 and 150 minutes based on the unit, based on how cool the hot pack had been. So they generally found that about 18 degrees Celsius rise happens in the first 10 minutes during the reheating process, and then about another 7 degrees in the next 10 minutes after that. So we need to recognize this in accommodating our layers of toweling. More might be needed at certain times. When we look at fluidotherapy, this is that forced air convecting those cellulose particles around. We get desensitization along with heating of those irregular areas of the hands or feet. Big benefit is that the patient can perform the range of motion while they're in there. I looked for some research that was more current on the benefits of fluidotherapy and did find a 2018 study, a relatively large cohort of 93 patients who presented with rheumatoid arthritis. And what they did was they had them perform fluidotherapy, or the other cohort received instruction in joint protection and exercise. So they followed the patients, reassessing at 3 weeks. There was really no difference in pain and grip and stiffness. And then they followed them out to the 12-week mark. And at that point, they found more that there was improved function in those individuals who had the joint protection and exercise as opposed to the heating. They presumed that the improved ability for dressing, office activities in the kitchen, utilizing their hands, was better because patients were educated how to adapt with their disease process versus just targeting the pain and impairments that they were having at that moment during therapy. I bring this up to consider that what is really our goal when we're using a heating modality, and it may not always be the best choice for our patient care. Ultrasound. Wish I could make eye contact as I throw that out there. This is always a debate over my decades in the field. We kind of see it go up and down. Where we're currently at now, just the very brief version, is that micro massage, those non-thermal effects. The research is really not agreeing that that's actually occurring. Where there does seem to be some merit with the use of ultrasound is for more of a deep heating modality, where that 1 megahertz is penetrating more deeply, the 3 megahertz is more superficial. I found an animal study where they looked at a pig hind leg that was heated using ultrasound, and they found that just altering that frequency did not really change the amount of tissue temperature rise in that sample, that you really had to consider the amount of reflection, refraction, and the other physiologic responses as the wave was getting to the target area, that there are more considerations than just the frequency for that depth of penetration if heating is to occur. Considering some actual outcomes, whether or not it's heating or not, what we want to see is improvement in our patient's pain and function, to know that our time use with the modality is actually beneficial for that patient. Many different studies out there really are showing that there isn't that correlation between the use of ultrasound and benefits for patient, looking at the knee for patellofemoral pain, hip osteoarthritis, ankle sprain, back pain, rotator cuff. There was really no significant benefit associated with that use of ultrasound for pain and function. If you are utilizing ultrasound, something that consistently comes up are contraindications over the epiphyseal plates of growing bones. I remember very early in my career having a debate with a physician where ultrasound was ordered on a young teenager. It was, I believe, a pitching injury, if I remember correctly. And I was not going to do it. My concern was the growth of the epiphyseal plates. Went back and forth. This was long before the days of the internet, so it was a lovely face-to-face with the physician about, from a very young clinician, not feeling comfortable doing it. And now, all these years forward, the research is still supporting that performing that ultrasound over the epiphyseal plates is a concern. That there was a rabbit study that was performed where they utilized ultrasound over the knee of the rabbit, and there were profound histologic changes when they used it at that therapeutic dose of 2 watts per centimeter squared. Another more recent study in 2011, looking at a rat knee, they did find that at the lower dosage, there was no significant statistical change in the negative impact on the tissues. But as we got up to that 1.5, those higher therapeutic doses of the ultrasound, that they did find cellular necrosis. So we're being cautious of not performing ultrasound over those epiphyseal plates. Shortwave diathermy is another intervention. Depending on where you're trained in the world, you may say, what do you mean it's a question to use shortwave diathermy? We do it all the time. Or what decade you were trained in. Other clinicians may say, oh, is that dusty thing that's back in the corner? Shortwave diathermy does have a lot of merits, and the more modern version of it is capacitive resistive electronic transfer. These are newer units that are undergoing FDA approval status for use in the United States, but preliminary research is showing that it does have a therapeutic benefit. The patient has a dispersive plant placed in one area, and then we can see the transducers here. There are 2 different types that are utilized during the intervention. So you get the benefits of both types of diathermy during the treatment session. And what they're finding in the outcomes is that it looks very promising to be beneficial as a deep heating modality. Looking at application to the hamstrings compared to a hot pack, that there was a higher tissue temperature rise. And more importantly, when they look at that hemoglobin release that's necessary for releasing the oxygen for greater healing effects, they did find that it was more beneficial with this type of diathermy combination. So supporting the idea that it might be more beneficial to stimulate the healing process. And the same thing was found when we look at the paraspinals. Functional application to the knee region for osteoarthritis. There were improvements in not only pain measurements, but also the functional scale on the WOMAC. They applied the intervention to the quadriceps area and the peripatellar region for the patients, and they did find that it was beneficial functionally. So you might see more emerging with this type of intervention. Hydrotherapy as an application. We may not see this utilized as frequently in the clinics anymore, but if you do have opportunities to look at expanding your use of hydrotherapy, there are benefits on the cardiovascular system for that population to increase their cardiac output. Respiratory, we have the hydrostatic pressure where they're combining that with the increased temperature at a mild level for the patient. They're finding that it can not only influence the oxygen transport, but increase cardiac output for the individual, increase that tidal volume, that displacement with inspiration, expiration. For our neurologic population, maybe aquatic therapy is an option in order to improve postural stability, do a combination of land and water therapy, as well as for our musculoskeletal patients. If you're working with an older population or pediatric population that have genitourinary or gastrointestinal challenges, water may be beneficial where it can alter the ability of that sphincter to relax so that they can have easier voiding. So different considerations as you look at interventions with the use of hydrotherapy. As we look at all the different equipment that we do utilize in our clinics, we want to make sure that we're performing our routine maintenance, that we have those logs, that temperature is checked, equipment is calibrated. And when that cord gets, pulled out of the wall by mistake, if it's half broken, that we're getting those things fixed and we're documenting these logs. We do need to make sure just to keep our patients safe. And then if something was to happen, you have those records that you can present to support that you were being as safe as possible for your patient. We may have our patients not only utilizing heating modalities when they're with us in the clinic, maybe the physician suggested that they use an over-the-counter heating product, or we're suggesting that they use something outside of the clinic. So they go to the local drugstore, look at the shelf. This image is just a small portion of the shelf. I went to one store just to look and I took a shot of it. And you can imagine for a patient, this could be very overwhelming. Well, what do you grab? You just start flipping it over and reading the box, or maybe it's something that a neighbor said worked great. As we look at the different over-the-counter heating options, one is moist heat, so that gel or hot pack, similar to what we're utilizing in the clinic, and there are some options that can be purchased for home use. Dry heat is what's utilized more commonly by patients at home, heating pads, those rice and bean bags, or our chemical heat wraps that they can buy in the different packages. And then we have our topical analgesics. And it's really deceiving to call these heating products. They're right on the shelf next to these other products, the moist and dry, that actually generate heat for a tissue temperature rise, are these topical analgesics that feel hot. They may feel warm and change that perception, but they're not, that cream or patch is not actually heating up the tissues. So the physiologic influence is different and the goal is different. I mean, not actually heating up the tissues. What we're going to do is take a look at each of these and see what we need to be aware of if our patients are utilizing them. As we look at the different over-the-counter application methods for heat, we have dry heat and then moist heat. Dry heat tends to be those bean bags, heating pad, and moist heat is going to be more like what we utilize in the clinic. Several different studies tried to look at, well, is one better than the other? Which one should you choose? And what I found is the research that I was able to pull from said that maybe consider that when you're utilizing a dry heat, that someone who has more sensitive skin, let's say they're elderly, it's more fragile to begin with, that dry application of heat may pull out more moisture from their skin. So it might be a little more irritating for them. Looking specifically at delayed onset muscle soreness and the application of a chemical dry like patch versus a moist heat post exercise, both did decrease pain. They did find that the moist heat would be applied like within the 2 hours immediately following exercise, and then the dry heat, those patches are over several hours. That both did have some benefit. There was an interesting one that looked at gait, comparing moist heat to dry heat. And if we think about heat, if we're trying to improve gait, we're going with increasing mobility, maybe decreasing discomfort that someone is having, really trying to influence maybe more of those viscoelastic properties. And what they found is that they did have increased step width, in particular with the application of the moist heat. They had wrapped the patient's legs in the different two types of heating. They thought that maybe with the moist heat, there was better influence on the muscles, allowed them to relax more, have better recruitment, that allowed them to have a wider base of support. They did find, though, with both heat applications that there was increased swing, decreased stance phase, so overall increased cadence with the gait. So again, pretty similar in terms of just that application example. When we look at heat wraps, I'll be honest, I was a skeptic. I go into doing my research just seeing what's out there. I may have a little preconceived idea of what I think, but I try to be very open and just see what I find, and that's what I'm going to pass along to you. So looking at these different, like little heat wrap pads that we have that you can buy over the counter, does this really heat the tissue sufficiently to have any benefit? Thermacare is one particular brand. There are others out there. This particular study happened to be specifically of these. And what they did was they applied the heat wrap around the knee, around the patella region, and they had the individuals, these were healthy, just sit, relaxed, watching TV, and then they had the control group sit doing the same thing. They inserted a monofilament into the muscle in order to assess the temperature. When they looked at the skin, there was a significant tissue temperature rise, which makes sense. It's superficial heat being applied. What pleasantly surprised me was the muscle, that there was a 3 degrees Celsius rise in tissue temperature when they inserted that reading instrument into the VMO. They went 1.5 centimeters in. And then even the joint capsule, there was almost a 3 degrees Celsius rise in the suprapatella area. They went about 5 centimeters in to look at that pouch for the joint capsule. Small cohort study, because I'm thinking having volunteers to have that heat probe inserted monofilament might be a little challenge. But some pleasant changes here. They also found that the visual analog scale changed, that the individuals did say that they felt warmth, that they did feel more relaxed, more comfortable, and there was a significant temperature rise. So I looked more into how these actually work, and I must say that it was interesting going back and forth with the company to have my questions answered to really understand this. When we open these up, they look like this, and we see these little plates here. These are charcoal. And then embedded in the charcoal, there's iron. So when they're opened up, the iron is going to interact with the oxygen. That is going to start the chemical reaction. There's also salt in there to control that rate of the reaction. And this is actually what's going to generate the heat. The temperature rise starts kind of slowly initially. It's going to reach about 40 degrees Celsius in its maximum temperature. That seems to happen within about the first 30 minutes, and then it's slowly sustained at that temperature over about 8 hours while the individual is wearing this. This is actually producing heat. So this is real true heat, looking at achieving the physiologic effects that we typically think of in circulation and tissue temperature rise. I apply this to my upper trap area, and what we see here after 2 hours is a shape here. We do see that erythema, tissue temperature change was occurring. It was warm, and I'll be honest, a little impressed with how it worked. So something we need to think about as our patients are utilizing these is when you flip the package over. And how many of our patients do you think are reading all this? Right? How many of us are reading all of it? We should. And here we go. When we look at these packages, there are a lot of precautions in utilizing all these different over the counter options. Some of them have metal in them. So if the patient puts this on, they're leaving it on all day. If they're going for an MRI or if they're coming into the clinic for us, we need to physically look and see and make sure they don't have something on if we're applying another heating modality. They shouldn't be going in the sauna, the hot tub, because you're going to be double treating that area. If someone has an AED and they're, at home figuring out where they want to put this, if it's coming over that anterior thoracic region, that could cause a malfunction of that device. If they have any type of implanted medication delivery device or anything, I would be concerned with this in that region. Again, because we're also heating, that could alter the delivery of the medication. As we look at topical options, when we ask our patient the mechanism of delivery, if they just say, oh, the doctor said I can put some cream on it, so that's what I'm doing, we have some follow-up questions to that, because what is that cream? That could be many different things. Corticosteroids, we know, are targeting the inflammatory process. They're immunosuppressive. Non-steroidal anti-inflammatories are such as Voltaren is going to be a local application to avoid that systemic and gastrointestinal complication potentially of something like ibuprofen. They might be smoothing on a pain reliever that is just some type of temporary relief. Maybe an Aspercreme or an Imbusol is a good example if they were putting that on their teeth. And then we have our topical analgesics, which are our rubefacins. This is where we're focusing today when we look at heat. The topical analgesics that are utilized, those are intended for a local effect. Exactly where they are smoothed onto the area, the cream, lotion, ointment, maybe it's even in a patch. The idea is for it to target that local area, usually for some type of pain relief. Transdermal medications, like we talked about, the intent there is for systemic distribution. That's not how what we're talking about now moving forward is being delivered. When we look at topical analgesics and they go into that huge case in the different stores, it can be very overwhelming. The key is that the ingredients are different, but they may also be the same. The mixes may be different. Maybe the physician told the patient, yes, it's fine to apply something for pain relief. And most people think, is it okay for me to heat? These topical analgesics, they may feel warm. They may alter sensory perception of heat, but they are not heating in the sense that we think of as clinicians. They're not generating a tissue temperature rise to elicit that cascade of physiologic effects. These are more geared at addressing pain. And it's important that we look at this because even here's one example. If you look at a brand on a shelf, and let's say they try the one with the little green person kicking the soccer ball. That didn't work. Well, maybe they're like, you know what? I'll also grab the other one with the body on the yellow bike. And maybe I'll smooth that one on too. It'll work. Well, when we flip over those labels, they may actually have similar ingredients and the person could be overdosing themselves, even if they swap between different brands. I like to think of it as if you have a cold and you are taking, a multi-symptom cold medicine, you're not also going to take cough medicine and a pain reliever and a decongestant because this had everything in it. We really need to have those labels flipped over and educate our patients because the ingredients may overlap. The most common ingredients, and you'll see them in different combinations, one is menthol. We also may see added to that methyl salicylate, camphor, And those you'll see in different combinations. And then capsaicin, we're going to see usually by itself, that it's not combined with others as an active ingredient. You want to note that the FDA does regulate all of this, that they are monitoring these companies. So we need to look at those active ingredients, knowing that they are putting some restrictions on, but the onus is still on the public to pick what's right for them and not mix them in the wrong way. I see this as an opportunity for us to educate our patients and ask them if they're using anything at home outside of the clinic, because they may not be thinking to tell us this. We're going to go through each of these and take a look at the different mechanisms of action for these topical analgesics. Generally speaking, they are working on several different pathways, but they are not working to elevate tissue temperature. That is not the mechanism of action. The goal here is more pain relief. And generally, they are focusing more on a counter irritant type of effect. That counter irritant effect we're all very familiar with, that we are engaging the sensory system in a way that we have greater stimulation through that afferent pathway up to the spinal cord to be perceived by the brain to result in that gating of the pain. Each different topical analgesic accomplishes that in a different way. Maybe it's just because you're rubbing it on the skin contributing. It's altering a sensory perception of temperature, warm and cold, or it may actually be irritating some of the nerves in that area. I think the marketing was perfect on one of the brands, and I can't remember which one. The way they described these to the consumer was that it diverts your brain's attention away from the pain. And I think that summarized it nicely in a simple way for the consumer to understand what it's doing. It's not actually changing the tissue in a way where it is healing whatever is causing the pain. First, we'll take a look at capsaicin. This is derived from chili peppers. So we think chili peppers, we think hot and spicy, and that is what it is derived from. And it's put into a cream, or this one has a roller ball on it to be applied. What they found with capsaicin is that it works through thermal stimulation. Specifically, it is going to bind to the transient potential valenoid receptors on our A delta and C pain fibers. As it binds to them, it is going to increase that nociceptor activation. There is an influence on sodium and calcium influxing in order to depolarize the nerve, and it is not going to feel great. We are increasing that nociceptor activation. What happens over time, they find with this, that initially there's that high sensitivity. And the more that it is applied, they're finding that the somatic pathway starts to change, and it actually changes the nerves in that area. It's called nerve defunctionalization. And what happens at more of a cellular level, they're finding, is that when the capsaicin is applied, it is stimulating those nerves, and then over time, they're seeing some cell apoptosis, so some death and defragmentation of the DNA in those cells, so actually degeneration of those sensory fibers, and then because they're degenerated, there's pain relief. Over time, this does regenerate back, but I'll tell you that after really understanding how they think this works, I have not gotten brave enough to actually try it, or I haven't been in enough pain to give it a whirl yet. But they are finding for some patients that maybe this is an option that would be beneficial for them. Menthol, we're familiar with different applications. Menthol provides that nice cooling sensation, so altering the stimulation on those sensory nerves. They also find that the TRPM8 receptors are activated. Those specifically work to play a role in pain control. And they find that, again, this is altering that nerve transmission, a little bit of a counter irritant effect because the individual is going to feel that cooling sensation instead of the pain. And this is going to then affect the nociceptor transmission in order to decrease the pain for the individual. There's a little more going on with the mechanism of action of menthol, and that's why often you'll see this included with some of the other ingredients that we will discuss. Menthol, when it is first applied to the skin, it is going to evaporate. And when we think of menthol, if we look, this is a patch, something that's warm and then cool and vice versa. Has a very distinctive smell to it. When this patch is applied and the menthol hits the skin, it begins to evaporate. And that's what gives that cooling sensation initially, that evaporation. As that is occurring, the body starts to go through a hunting reaction where now it vasoconstricts a little bit because it's becoming cooler. It's going to vasodilate in that responsive hunting reaction. And we end up with this cyclical vasodilation, but because the patch is still on and more menthol is being delivered, now we're looping back around and we have more of that cooling. So it's going to continually occur. And it's the basis of that icy hot, warm, cold perception that is occurring. There does seem to be a small influence on the vasculature in that area, that cutaneous kind of intermittent circulatory change, which is why it's included as an active ingredient with some other combinations to increase their absorption. So that method of delivery can help amplify the response from the other components in the cream or the ointment. Camphor might be one of those that is also included. Camphor actually has an interesting history. If you're in more northern Florida, if you look out, you might see those trees with those kind of shiny green leaves. And if you took them off and cracked them, they would have a very similar aroma to like a vapor rub. And these are going to be included in order to, again, change the heat and cold sensitivity. They are working on those TRPV1 receptors on our A delta and our C fibers to, again, inhibit that nociceptor conduction because they're being stimulated in a different way. That overstimulation desensitizes them, and then the pain is relieved. That's why these are temporary uses. The FDA does specifically regulate the use of the camphor, and if you read the FDA letters and cases, I get very lost in some of it because I find it comforting and interesting what goes on. There was one in particular with a company that had an ointment out that had camphor in it. The FDA says somewhere between the 3 and 11% potency is what's in that range that's safe and effective for what we're discussing that they've approved for usages. Well, this particular company, they weren't even in that range, and their claims were vast. They said that this cream that they had is going to treat fibromyalgia, sciatica, the flu, I think they even mentioned so many different things, and they were reported to the FDA, and the FDA, sent them a letter, a cease and desist, or we're going to seize all your product. So these things are monitored, and it's comforting to know that. Methyl salicylate is wintergreen oil, another very distinctive aroma that we know of as we look at our gums and our toothpastes. This is derived from salicylic acid. And when it's used in very, very low quantities, it's just like a flavoring. When it's used in a different concentration, it starts to allow for an analgesic effect. When we look at the methyl salicylate, it is going to give that same analgesic effect that we've discussed with the other topical applications. And what they have found with it is it has a lot of potential drug interactions. That its mechanism of action, it comes from that same family as aspirin. So someone who has an aspirin sensitivity needs to be cautious in using any creams or ointments with methyl salicylate in it. They also found that a small amount, even when it's applied topically, that it does transfer into the systemic circulation. So if someone's over applying it or they're applying it more frequently than the time period that's indicated, that they could potentially be overdosing. And we want to monitor patients also, as I said, who have that aspirin sensitivity. The gentleman here is developing a rash reaction. The concern, because a little bit of it does become into the circulatory system, is that it can raise to toxic levels, particularly if someone is also taking aspirin. There needs to be a awareness of that. We also really need to be cautious and educate our patients who are on anticoagulants. Anticoagulants, we know, are our blood thinners, and those INR levels are very closely monitored. If someone's also using an ointment, they looked at patients who had heart valve replacement, who also presented with joint pain and were using these different topicals for that myalgia or joint pain. And they pulled out little venous samples, distal from where the ointment was applied, and they actually found that there was a change in the platelets, that there was platelet resistance to clumping, and their INR values were more difficult to manage. So the individuals we want to watch if they're having increased bruising or bleeding, that they can't be combining this. There's a potential danger. There's also concerns related to toxicity when we look at methyl salicylate. And the FDA views this as such a significant concern related to toxicity that they keep the concentrations low, around 5%. And if you go above that 5%, they actually control how large the bottle can be. They talk about the font size that the warnings have to be in, that it's just for minor aches and pains, that it can't continue for use for more than 10 days, keep it out of reach of children, to try and keep the public safe. Because while there are some benefits of it, that there are these great concerns of toxicity for the individuals. Toxicity can occur because it interferes with the Krebs cycle as the plasma concentrations increase, so that it's affecting every system. The GI, hematopoietic, pulmonary edema can even result. And I pulled some data on this, looking at a 2017 report from the American Association of Poison Control Centers, and there were 1,200 exposures of toxicity. And of that, 950 were in kids under 5. Here's why. One contributor. Both of these tubes are in the medicine cabinet. Which one's the toothpaste? Which one's the methyl salicylate for the joint pain? Both of them, if you pop them open and smell them, have that nice minty scent, but one's toothpaste, one's not. The consistency is the same. The concern is that a child may ingest the ointment, or it could be misused by someone if they're confusing it with the toothpaste, and toxicity can result. Just 1 teaspoon of the ointment can be equivalent to 22 tablets of adult aspirin and have all those significant effects on the body. So the FDA is really restricting this. Caution needs to be taken. One physician said that he gives a list to new parents of 1 swallow will kill, and he has these ointments placed on that to show how cautious you need to be. If you're working with different populations that might be using this, if you're working in women's health, be aware that we have an opportunity to educate, because toxicity can occur in two ways. It could be ingested or it could be percutaneous. If someone is applying it more frequently than they should, using more than they should, toxicity can result. Also, if someone is applying heat over it, it's going to increase the rate of absorption that can become toxic for them. Think of a parent or grandparent that may have put the ointment on themselves and they didn't wash their hands well enough before going to change that diaper. Or that new mom that maybe has some shoulder pain that spread it on. Well, now it's getting very close to the breast tissue. And, could the baby be ingesting that? They've also found, if you're working with women maybe for sacroiliac pain during pregnancy, they shouldn't be using these creams because it does cross the placental barrier. It poses a risk for the fetus and then a risk for the mother during childbirthing because it has potentially thinned the blood. We need to really be cautious with these over-the-counter products. It doesn't mean that they're free of potential harms. There was a very sad 2007 case of a high school athlete who was using 3 different over-the-counter products and accidentally overdosed. The signs of toxicity that we're monitoring our patients for: if it's percutaneous, it tends to be more chronic, more CNS type of symptoms. Acute tends to be more of the ingestion related symptoms that we're going to see with the patient that occurs a little bit more quickly. How toxicity is managed is evolving because of the unfortunate prevalence that they're seeing with it. There was an expert panel that came together. It was individuals from the American Association of Poison Control Centers, the American Academy of Toxicology, and they said that with ingestion toxicity, the individual should not be induced to vomit, that the key is to get them to the hospital so they can get that activated charcoal. With percutaneous, washing it off is the immediate control mechanism. And what they're finding is that as the plasma concentrations increase of this, the rate of decay is altered, and medication, the application that should maybe take, over 8 hours, it'll dissipate to avoid toxicity. That once the levels are high, or particularly if it's ingested, it could take 20 hours to clear it. And then if it's being reapplied, that's the concern. So we need to be cautious. As we look at all the different over-the-counter products, burns are another concern that we may have. The FDA says that this is rare, but it can happen if individuals applied a cream or an ointment, and maybe a short while later, they're like, oh, that really isn't working. They put one of the, heating pads over it. We can see the line demarcations here where the individuals actually had the pads that caused a burn on their skin. If someone is applying a cream or joint in a joint crease, under the arm, at the hip fold, that insulates it and increases the rate of absorption. We need to know before they came in the clinic if they applied the cream or the ointment, and they shouldn't be putting some type of occlusive dressing over the top of it because they're going to be unable to dissipate that heat. Given all of these considerations, you might wonder, is it worth it for patients to even try utilizing some of these? So I pulled some research, and looking specifically at outcomes related to pain, there was a 2014 Cochrane review that said there's really no good evidence specifically for pain that methyl salicylate or the capsaicin improved it. Same thing with myofascial pain. It, wasn't really any better than other interventions. When we look at outcomes for the muscle, though, where we're trying to alter the physiologic response, maybe increase heating of the muscles, we are seeing some potential opportunities here, specifically with the heat wrap, because that is actually increasing circulation to the area. has found significant increases in tissue temperature, as well as muscle temperature and blood flow. One study said that there was a 150% increase in the muscle blood flow with the application of the heat wrap. Other studies looking at more of the patches and the warm, cold creams, those didn't really have a significant change in the blood flow or the tissue temperature, which we wouldn't expect now that we understand more about the mechanism of action. Where there does seem to be an opportunity is with the capsaicin, specifically for neuropathic pain. And just to remind ourselves the difference between nociceptive and neuropathic pain. Nociceptive pain is where the neurons are detecting a noxious stimuli related to a lesion or a disease. Those are intact nerves. Neuropathic pain, those are damaged nerves that are involved in the pain signaling. Those are the ones that seem to be responsive to the capsaicin. So an individual with peripheral neuropathy from diabetes, post-herpetic neuralgia, that would be shingles, HIV neuropathy, they're finding that there is a benefit for the application of the capsaicin in order to decrease their pain. They actually said that for individuals with the HIV neuropathy, it did only help 10%, but for those 10% of the individuals in the study, they had a 30% decrease in their pain. So that's pretty significant. And they're actually looking at the capsaicin, doing more of a prescription patch of it for improved absorption. An interesting outcome that they also saw is not only that pain was improved, could improve quality of life, that sleep quality was better. And that's important, we know, for all of our different body systems. Those are our over-the-counter applications, some of which actually provide heat. Now we're going to shift gears and come back into the clinic and take a look at our more traditional methods of application and our impairments that we're managing utilizing heat. When we're in the clinic, we know that we're utilizing modalities as a component of a well-planned, functionally oriented treatment program for our patients. There is the Choosing Wisely campaign, if you're aware of it, through the American Board of Internal Medicine. It's an attempt to make consumers aware, and every discipline puts out the 5 things that clinicians and patients should question. And for both PT and OT, PT says don't employ passive agents except when necessary for participation. OT Association said, those PAMs should not be used without being purposefully used as part of other intervention-based activities. So we know that this is just a piece of what we're doing. As we look at different pain management outcomes and different use of heating modalities, we know that many patients present with back and neck pain. And analyzing that, the thought we want to consider is, well, does heating the area actually improve the pain for the patient? And when we look at the different physiologic effects contributing, is it muscle tightness? Is it a pain spasm cycle? In 2018, the Global Spine Care Initiative had representatives from the United States, Chile, the UK, Canada, from a lot of countries come together and analyze all of this research related to spine care and back pain. And pulling the pieces related to superficial heat, their conclusion was that superficial heat is recommended and may be beneficial in the management of acute pain. But when we look at the management of chronic back pain, it's not recommended. They said that the number one recommendation for chronic pain is patient education and self-care when it's related to the back, that heating really didn't have a positive benefit. Analyzing cervical pain, considering both superficial heat as well as ultrasound in acute and chronic, there was no benefit. They even looked at, what if it was combined with other interventions? And it really wasn't found to be particularly beneficial, even when combined with mobilization. they said that actually traction seemed to be more beneficial for the cervical pain population. As we come further down the extremity, looking at knee osteoarthritis, some studies that I looked at related to the application of heat to the quadriceps area and around the knee. They did find that there was some improved pain and function in this particular study, so it might just depend on the area that we are treating. When we consider soft tissue tightness and using heating modalities to get viscoelastic change, when we consider soft tissue tightness and using heating modalities to get viscoelastic changes and increase range of motion for our patients, what we're envisioning are our different types of collagen. And our type 1 and type 3 collagen are what we are focusing on that are restricting range of motion for our patients and those different periarticular structures. Historically, we've thought that we heat, we increase collagen extensibility, we decrease that connective tissue viscosity, and that's how heating helps make gains in range of motion. And then as the tissue cooled, there's kind of like a resetting of it to maintain those gains. Now, our current theory has changed, that really the focus is on improving stretch tolerance and that heating applies sensory changes that allow for a better stretch to be performed to reach those limits to induce all the physiologic changes that occur at a cellular level that lets stretching work. So it's more the heating is allowing the patient to get a better stretch, and that's why it's effective. The individual in this image, if they have burns on that anterior leg, we can see the facial grimacing if the clinician is just stretching. Well, if they applied heat to that first, it might allow that patient to get to a more tolerable endpoint to hold that stretch so that the cellular changes of stretching can occur to give a better benefit. We might get to a later end point of the stretch to make better gains. That's where our current theory is. Looking at the different outcomes to see if this holds true, several different studies compared, for example, shortwave diathermy and hot packed for ankle range of motion. They did find a more significant increase with that deeper heating from the shortwave diathermy, with a small increase in range of motion from a hot pack. And then they looked at, well, maybe the type of stretching plays a role. So they applied in this other study heating to the hamstrings, and they performed static stretching that yielded almost a 12-degree increase in range of motion, and then more of an active hold relax type of stretch, which yielded an 8-degree increase in range of motion. Compared to the hot pack alone, it was only around 1-degree increase in range. This was supporting the idea that something else is happening with that application of the heat, and also engaging a better stretch seems to increase range of motion more. The timing of the stretching is also important. And we discussed that we need to have that 4-degree vigorous heating to get all of the different physiologic effects that we discussed. And the timing of that has to be either apply the heat and stretch while it's being heated, or immediately after it within about those first 3 minutes. There's this thing called the stretching window. And it goes back to older research from the 1990s, where they looked at tissue temperature rise in the gastroc, and Draper tracked how quickly it cooled off after the heat was removed. And he found that by about 5 minutes after, we were outside of that therapeutic heating range and down to 2 degrees Celsius. So our ideal heating window is within those first 3 minutes of the application of the heat. That's why our sequencing is so important, that as we position our patients, we're going to look at applying heat and stretch together, and then go right into our stretch with our heating. So we want to consider that to increase that tolerance and gain a stretch as the heat's being applied if possible. Delayed onset muscle soreness is another indication for heat. We might not be thinking that as an option, and part of it is depending on when you were trained and whether or not you've been able to keep up with our ongoing changes on this theory. Originally, they thought that lactic acid buildup is what caused delayed onset muscle soreness. And this occurs at that pain and discomfort, deep achiness, loss of power and range that happens about 24 hours to 72 hours after someone participates in rigorous activity that's high intensity beyond what is typical for them. And I emphasize that because this is not only our very high, vigorous exercising patients where they're doing, 50 burpees. This delayed onset muscle soreness can happen for any patient where they're participating in that rigorous activity beyond their baseline. So that can even be our older patient who's walking further or walking more. Oftentimes it's after more eccentric type of activities, but anything with a high metabolic cost. So originally they thought, going with that, lactic acid buildup. Then the theory changed to, nope, it's muscle spasm. That's the culprit. Moved on to, no, there's some kind of little inflammation that occurs of the muscle, or some type of enzyme shift that's damaging the connective tissue. Where we're landing currently with delayed onset muscle soreness is that damage to the sarcomere seems to be the culprit. That sarcomere damage is what causes this delayed onset muscle soreness, and we need to find a way for the person to continue to be active, to press through that in a safe way so that they can maintain and continue to improve their strength and function. This could even be someone who's returning to work, that longer shift, that more activity brings on a muscle soreness. This is where heating comes into play. So the research is looking at if it's sarcomere damage that has to heal. When we consider physiologic effects of heating, those would go hand in hand. That we can look at in the research, they're finding that when that heat is applied after exercise, the granulocyte concentrations were altered. There was less swelling of the fascia that occurred, both indicators that there was healing occurring in the tissues. And the benefit is that if we can preserve the patient's strength and decrease their pain and soreness, they will continue to be active and make more of their gains. In this particular study, they looked at a slow application of heat over 2 to 8 hours that allows for a little more prolonged vasodilation to encourage this healing process. And they were looking at, well, does it make sense to use some type of patch slowly over time after exercising to help encourage this healing of the tissues? As we consider heat versus cold for the delayed onset muscle soreness, not only will the heat give a little analgesia and promote the healing, if there is damage to the sarcomere, some clinicians may say, well, maybe we want to do some cold to kind of calm that down a little bit more. A couple of different studies have looked at that. They looked at heat wrap, where they did find and improved the muscle soreness. And then another study compared the use of a cold pack to that heat wrap treatment. They did find that specific related to the heats. This second one was applied to the low back. They found that the individuals who used the heat instead of the cold, they had decreased disability scores, they had increased self-report of improved function. There might be some opportunities here to try heat to see if it does give you more benefits if you've been using cold or not using something to address delayed onset muscle soreness. The image that we have next is a reminder for us. I found this posted, and the individual, this is their knee. They have a dry wrap around it. And the posting caption was, as usual, starting my day with Tylenol, pain gel, my lidocaine patch, and my heat wrap. And that right there, is everything that we've just spent all this time discussing we need to avoid. And to figure out, why is this person in pain? What intervention do they need? Many concerns about combining for burn, for toxicity. And I see opportunities here for us to work with our patients to improve their function and avoid potential harm. Contrast water therapy, you may think of this as contrast baths. The newer terminology is contrast water therapy, where you're going to have an individual immerse either their whole body or their hand, their foot, their limb in hot water for about 1 to 2 minutes, and then they're going to go into the cold for about another minute, and they're going to keep flipping back and forth. I tried to find very specific protocols, and to be honest, there's a lot of variability in it, anywhere between repeating the cycle for 6 minutes up to 45 minutes. Generally speaking, the research did say to start on cold and end on the hot. And the alteration, the idea is that we're encouraging more of a vascular response, that we're increasing circulation. It's going to support the lymphatic flow to promote healing, relax the muscles, decrease joint stiffness. And when we look at this, we're going to, yes, maybe picture these high level athletes. And if you're not working with that population, you might wonder, well, how is that going to help delayed onset muscle soreness in the patients that I am working with? Consider that you could have a patient, if it was a long shift at work and their feet are bothering them, maybe they do immersion. Or that individual who is a chef or a hairstylist or a musician, they can utilize it just for their hands. There's different ways that we can utilize this on a smaller scale to target that delayed onset muscle soreness for our patients. As we look at the outcomes, the research is supporting that for delayed onset muscle soreness, that the contrast water therapy does seem to be better than water immersion alone or just some type of passive recovery. It didn't necessarily prove better than other interventions because the exact mechanism isn't completely figured out. They're just saying that, there is no one way to treat every patient. And this might just be another option to try in order to attenuate that loss of strength that occurs because of the soreness so that the individual can not only be more comfortable, but continues to function. Delayed onset muscle soreness, when we consider it related to our patients with diabetes, we have a couple of extra considerations. We know that individuals with diabetes, there are significant benefits of exercise in order to help improve their glycemic control, decrease their A1C levels, to improve that insulin sensitivity so that they can decrease their dependence on the insulin. They've also found, though, that someone with diabetes, when they exercise, they already have existing sensory damage. There tends to be damage to the endothelial layers. And in terms of metabolic capacity, what they found is after exercise, when they did blood draws, they found that the myoglobin levels were different, that there were more indicators of muscle damage. And they're finding that, yes, there are great benefits to exercise, but the individuals seem to be at a greater risk of delayed onset muscle soreness. That presents a couple of challenges. That if there is significant delayed onset muscle soreness, then the individual may not sustain the exercise program in order to get the gains. So we have to address that. On the flip side, if they have sensory impairment, they may not be aware of the delayed onset muscle soreness, and they may be at a greater risk of injury if they go in and they overdo it. It's important to consider that we educate our patients with diabetes on delayed onset muscle soreness, and then look at, maybe is there an opportunity with modifications to safely use heat to try and manage it so they can continue with an exercise program to get to the point of these benefits for managing their diabetes. As we look at another condition that involves the muscles, we're going to discuss spasticity. This is specifically occurring following a neurologic injury. To distinguish muscle spasm from spasticity, muscle spasm is that protective response of the muscle where it's going to go into a contracted state to try and stabilize an area that has been injured. Spasticity is different. Spasticity is occurring in our patients who have central nervous system damage, such as from cerebral palsy, cerebrovascular accident, traumatic brain injury. And we're seeing that the muscle is at rest, and there is triggering of that stretch reflex with the signal going up, that afferent fiber to the spinal cord, and then the efferent signal coming back down telling that muscle to contract. Normally, when this happens, our body from our higher cortical pathways is going to calm that and say, you know what, it was just a slight shift, even though it was velocity dependent, and it's not going to cause that continuous contraction. In a patient with a neurological central nervous system involvement, they don't have that higher cortical level dampening this stretch reflex, so it continuously fires, leading to contraction of that muscle, even though the patient is not volitionally, requesting that muscle to contract. This can lead to significant pain and deformity for the individual and lack of function. Oversimplification of what is occurring, however, it gives us the information that we need to look at the application of heat for individuals who present with spasticity. And one of the complications that are concerned when someone has spasticity is the development of joint contracture. We're looking at this individual who has a significant equinovarus position of their ankles due to that spasticity of the gastroc. That upper motor neuron lesion, the individual has the spasticity developing where they have that obligatory response of the muscle to be contracting. In this example, pulling them down into that plantar flex position, over time, because they are in that contracted down position, we start to see viscoelastic changes in the muscle, the periarticular structures, and we ultimately see decreased extensibility of the muscle. Well, now that muscle is more rigid, so it has a lower threshold even to that triggering of the stretch of the muscle spindle. So maybe this patient just swinging their legs over and putting it down on the floor, that's enough of a stretch to stimulate this reflex and augment that stretch reflex even more to have greater spasticity and resistance to motion, pulling them down into this position, and ultimately we have more joint contracture developing. In order to manage a patient that presents this way, we have two aspects to consider. We need to address the spasticity, and then we also need to address the viscoelastic properties of the tissue. So we need a couple of different strategies. Cooling is well established, the use of cold in order to slow the nerve conduction velocity and decrease spasticity. Research is showing, though, that warming the tissues does seem to have those bifold kind of benefits to address both aspects of the problem. So it is going to help decrease the muscle spindle firing, to try and calm down that reflex arc a little bit, to decrease the spasticity. And then once that is minimized, now we can go in better with a very purposeful, slow, controlled stretch in order to address that viscoelastic component, breaking into this cycle two different ways. Examining some research related to this, in rat models, they induced a spinal cord injury, and they then looked at the tissues and applied stretching with heat to those spastic muscles. And they analyzed the joint capsules also. And what they found is there were benefits in terms of decreasing the gamma neuron firing and controlling that passive resistance to movement. Some other studies looked at individuals with hereditary spastic paraparesis, where they applied heat to the lower extremity, and then they applied cooling to the lower extremity in order to see the difference in response of the tissues and the ability of the individual to recruit their musculature. And they did find that there was an ability to decrease that spasticity to get more gains in passive motion. And then they actually found an increase in conduction velocity of the antagonist muscle. So if it was that gastrac, well, that anterior tib was able to induce a stronger contraction and have better recruitment to try and overcome that spasticity. So once passive range was gained, there was a better hope of gaining active control to preserve it. Consider maybe you're trying heat in a safe way, particularly if your patient has decreased sensation, to try and influence spasticity and make range of motion gains. As we look at the different methods of application, we have several different considerations. We could use a foot bath or paraffin if it's just for the distal extremity. One study looked at utilizing the application of paraffin to the hand for individuals who presented post-CVA with upper extremity spasticity and hemiplegic shoulder pain. Over a period of 4 weeks of that paraffin application, they found that the modified Ashworth scale was improved, so that's how much spasticity was present, decreased. The visual analog scale for that pain diminished. Their Brunstrom level progressed, so that means that they were moving more towards being able to start to isolate out some movements, so that antagonist muscle was starting to contract better. So it looks promising. Neutral warmth. This started with Rude way back in the 1940s and 50s using comforters to try and warm patients. In the 80s, it moved more of this neutral warmth, enveloping the limbs in kind of toweling to try and warm them. The idea is that autonomic feedback from the warmth tends to induce more of a reflexive calming that helps decrease the spasticity. And kind of a more modern interpretation of this neutral warmth is when we're applying different sleeves or splinting or serial casts, that it's insulating the limb a little bit to warm it. Circumferential compressive pressure is inhibitory, and then positioning the patient in a prolonged stretch seems to be beneficial in order to help make range of motion gains. Someone who maybe has more regions of the body where we're trying to minimize the spasticity and encourage volitional movement, Watsu, is when we utilize the pool at a warmer temperature. It's very slow, controlled, rhythmical movements at the surface in order to decrease spasticity. And some of the research is showing that this is promising as an intervention to help increase movement for the individual. And it has been shown to improve their levels of spasticity. Let's flip this. If we are saying that the research is supporting that warmth helps decrease spasticity, not only do we want to maybe consider adding heating, we want to make sure that the individual is maintaining their body temperature. Consider this individual is coming into your clinic for treatment and they have spasticity of their lower extremities. It's cold out, they're dressed appropriately in this image on the left to keep their body warm. Imagine if they couldn't afford pants, they couldn't afford socks and to be warm, and they come into your clinic out from the cold, their level of spasticity may be increased and you'll have to overcome that. What they find in looking at individuals who had spinal cord injury, multiple sclerosis, CVA, is that particularly when their lower limbs, the surface area was exposed to colder weather temperatures, that the blood shunts to the internal organs to try and protect them. The lower extremities cooled even faster, that further increased their spasticity and increased their resistance to movement. We want to be aware of this when our patients are coming into rehab. Maybe they need a referral to an outside source if they don't have the right clothing. Consider, where do we have them sitting in the waiting room? Is that cold breeze coming in, or in Florida, are they right underneath the air conditioning vent? Maybe you need to provide some type of blanket, let them insulate a little while they're waiting in the waiting room so their musculoskeletal system and neurologic system is better prepped for us by the time that they come in. If you're working in pediatrics or with individuals who are caregivers for others who may not be able to communicate if their spasticity is increasing, or if they're cold, or if they're warm, maybe the care provider can look at the level of spasticity, and if it's increasing, there are many things we want to see that could be potential triggers of that, but maybe they're just cold. So consider there are different ways we can use this information. With individuals who present with multiple sclerosis, we need to be extra cautious in applying heat. And I want to highlight Uthoff's phenomena if you are not aware of it. And even if you're more of an orthopedic clinician, you may have patients with multiple sclerosis who are coming in because now they've sprained their ankle, and you'd want to be aware of this, in addition to if you're working more commonly with this population. Uthoff's phenomenon, it's an adverse reaction to heat, and it makes the individual appear like they're having an exacerbation of their symptoms. They may have a increase in their symptoms, which is usually a decrease in their function, significant fatigue, and this is induced either by internal increased temperature, core temperature rise, or external application of heat. It could be they're sitting outside in the sun. Maybe you have them in the clinic by that window and the heat is beating in. If you just had them exercise too much, so their internal temperature is increasing, it could lead to this pseudo exacerbation. The research seems to say about 80% of patients with multiple sclerosis do experience this, so we do want to educate them on it. It's not a true exacerbation of their symptoms, it's just this abnormal response to increased temperature because of the impacts on the nerves. A study looked at the application of heat to see, well, how does this really affect the ability to exercise and core temperature in someone with multiple sclerosis? And it was in Australia, they had a cohort of 44 individuals, and I loved their detail in this. For every participant who had multiple sclerosis, they had an appropriately like age matched and characteristic matched control subject to look. And what they did was they had the individuals cycling, and they assessed the resting core temperature, and they found that at rest, core temperatures were the same. When they had the individuals start exercising with the cycling in a warm versus a hot environment, they found that the response of the individual with multiple sclerosis was a little more dysfunctional in terms of particularly their sweating response and their ability to control their core temperature, that they saw more significant increase in temperature rise for the individuals with multiple sclerosis because they weren't able to control their sweating response to dissipate the heat. And that led to the pseudoexacerbation. I love that the researchers didn't stop there. They took it a step further and they said, okay, well, is there something we can do to help them better control that core temperature? So they had the individuals ingest cold water versus neutral temperature water. And surprisingly, they found that when they were ingesting the cold temperature water, that it contributed in a positive way to lowering that core body temperature, and they were able to exercise 30% longer before they reached that point of fatigue and exhaustion. That might be a simple, inexpensive way for someone with multiple sclerosis to try and control their fatigue and their exacerbation symptoms relative to heat. Now, still our traditional means need to be put in place, but maybe they need to make sure if they're outside they have enough water, they keep it cold, they're returning to work. This might be another compensatory mechanism we can add for them. Back to healthy populations, look at hyperthermia, increased temperature. There was a trend a while ago where the thought was if you exercised weightlifting in these really hot environments, that you would have greater hypertrophy of the muscles. Research didn't really pan out that way. Looking at resistance training at 23 degrees Celsius versus 40, there was no change in muscle mass, speed, agility. That the accumulation of metabolic fatigue indicators were about the same. There was no significant difference in those, which indicated there were no physiologic changes that would contribute to that muscle hypertrophy. They also looked at more kind of cardiovascular endurance related to exercising in a very hot environment versus a cooler environment. And they actually found that there was a decrease in mean power when cyclists were in a hotter environment versus a cooler environment. And I think living in Florida, I can relate to that. That you go outside, and some of those days it is just hot and it is hard to do anything. And I think we need to consider that, particularly if you're working in home care, whatever part of the country you're in. If patients have been indoors because it's been colder out, and now suddenly it's warmer out, and you decide to walk them outside, um, are they physiologically able to adapt to that change? Can we really expect that walking that 50 feet inside in a controlled temperature environment, now going outside to a hotter temperature, can we expect that same 50 feet out of them? Or maybe if they can't control their thermal regulation as well, it might actually decrease their muscular performance. There's a lot more research looking at this, that relationship between core temperature and performance. That there are so many situations where individuals need to maintain their capacity for exercise in a hotter temperature than where they trained. Not only that patient where maybe they're rehabbing indoors and now they go to work at a job outside. Did we prepare them appropriately for that? Or consider individuals who are in the reserves or firefighters where there has not been an incident that they had to go to, or now they're traveling to a different part of the country to help out with a disaster and the temperature is different. Our military service personnel, that it needs to be a piece, and this is recognized in their training, to prepare their bodies to react appropriately. And what happens is, if you're exercising in unaccustomed heat, you're performing your activities that are very strenuous for you in an environment that much warmer than what you're used to performing in. What happens is the body's core temperature is going to increase more rapidly. What the body should do is sweat to try and evaporate out. We're going to convect through our circulation more towards the surface to dissipate that heat. If that is not successful, if we can't cool our core temperature enough, our central nervous system is going to recognize that, and it is going to start protecting itself. It's going to say, you know what, this activity you're participating in, we can't sustain this. So the cardiovascular system is going to become more suppressed, decreasing cardiac output, decreasing the CNS drive for power and strength. And we're going to see a decrease in that power and strength. So the individual is not able to perform as well. This doesn't mean they're not capable of it in a different environment. It just means because they didn't control that core temperature, now we're going to see higher cortical centers taking over and saying, you know what, I'm going to move into a protective mode. In doing so, it decreases the power output, the strength, the endurance for the person. That central nervous system regulation is called heat stress. And there tends to be more of a dose response relationship, that these thermoregulatory sensors come into play. And it is triggered when we have this temperature difference between the environment and the person's body that should normally allow that hypothalamus to recognize the tissue temperature rise, vasodilate superficially, release that heat. But if the body is unable to do that, then it's going to say, I have no choice but to decrease the metabolic demands of the body by decreasing performance. And that's why we see individuals not being able to perform as well in those hotter temperatures. Humidity can also play a role in this factor. Humidity is that amount of moisture that the air can hold. And if you're training in an environment that tends to be more dry, our sweating mechanism works a lot better. We're able to evaporate out that heat to cool our core temperature. If you're in a more humid environment, that sweating evaporation is inhibited, so the core temperature continues to rise. But the body is still trying to sweat. It just isn't effective in allowing the release of heat for that core temperature to decrease. So then the person's getting dehydrated because they're trying to sweat, but it's not effective. So their core temperature is still rising. And we need to be aware of this as we change training and work environments for our patients. Consider these different factors. How do we tackle this? There are several different techniques that are available to try and manage core temperature for individuals. This may involve cooling, which seems to be the simplest way, that during that activity, the individual's performing as their core temperature is rising. Things are done. Ice baths, ice packs. Maybe they go near a fan. They have the moisture wicking clothing that can allow for a better sweating mechanism, and that could be used during the activity in order to let the person cool. The other option is to kind of pre-plan it, think ahead. Well, what if we teach the body how to respond better when performing in hotter environments? That heat acclimatization, where you're going to get someone to acclimate to working in a hotter temperature, either through heat controlled environments, increasing their core temperature at a controlled rate while they're training. And now they're even looking at using saunas and hot tubs to kind of replicate the demands of exercise in different environments. And I'll tell you, particularly in Florida and probably other parts of the country, but it becomes an issue down here in South Florida when kids are returning from summer break, where they've probably been inside a lot and now they're going back to sport competition in August in 100 plus weather, and they're just not used to it. And that athlete that was performing at a certain level at the end of the year in cooler temperatures now is being exercised at a point that may be too strenuous for them. And we see a lot of detrimental effects of heat. So, something else to consider if you're looking at a community outreach and education, you might want to pull some of this information in. Heat acclimatization works like this. If we understand now that the body starts to suppress endurance and power in order to protect itself and not allow those metabolic demands to continue that are increasing core temperature, that can become dangerous. The mechanism that should be working to dissipate all of this heat is our sweating mechanism, that we're evaporating that heat out to control our core temperature. And whether it's for work or recreation, training is going to, instead of at an earlier point in time, so the individual is exercising, and at some point they reach a core temperature that starts the sweating mechanism. When we acclimate them to hotter environments, the key is to get this sweating mechanism to kick in earlier. So as that sweating mechanism kicks in sooner, that gradient is altered so they can continue to exercise longer in warm temperatures, retaining their cardiac output, retaining their muscle strength and power for a better level of functioning. The different physiologic responses to heat that we're looking at, the goal is to control that thermal comfort to allow the individual, yes, to be more tolerant of the hot temperature, but the real key is to control that sweating and superficial skin blood flow that ultimately regulates our core temperature so that we can retain muscle power, aerobic capacity, and cardiac output. And in doing so, we are going to decrease that core temperature. I always remember at this point in the lecture the season when my daughter played beach volleyball. And it's a perfect example of this, that all summer, the kids are training outside, but you drive them to practice on the beach or at the sand court and drop them off and either go sit in your air conditioned car or go back home to cool off and then come back and get them. The days you go to these competitions, you're outside in the Florida heat all day, you're a mile away, you lug the cooler across the sand, you're hot outside, and you're like falling apart by the time you're trying to bring that cooler that's now empty and somehow heavier back to the car. But the kids are all day, they're competing, doing great. They were acclimated, I was not. So it reminds us that in our patients, there's so many different times that this will come into play, even not just that high level athlete who's going to compete in a different environment. It might just be that patient who is now going back to work outside, or we need to think about, are they able to tolerate the environment they're going back into? If you are working with those athletes where they're going to train in one area and now need to go perform in another part of the country where it may be hotter, there are ways to train the body to be able to sustain that same level of performance even in the hotter temperatures. There are many different protocols out there, but generally speaking, to achieve all of these benefits that we're looking at for ultimate performance, they say about 10 days to 2 weeks before the individual will be participating in that hotter environment, they're going to start training, recreating that warmth. They're going to either maybe layer up their clothes, go out at a hotter time during the day, in order to start teaching their body for slow doses, 90 minutes, working up to maybe about 2 hours, how to control that sweating mechanism and maintain your output. They say initially it's uncomfortable, but about 4 to 5 days in, the body starts realizing this and starts adapting for all these physiologic benefits. So then they travel to where they're going for their event, they participate in it, and then gradually the body's acclimation starts to return to baseline after about 3 weeks if they don't continue exercising in that increased heat environment. The different training methods that can be utilized would just be if you can get out in that same situation, there are some different heat controlled chambers that could be utilized, but those tend to be very expensive. One of the least expensive ways is you ever wonder why tracksuits are that vinyl material that makes you sweat? Ah, there we go. We're insulating to kind of train the body. They're also looking at using a sauna or a hot tub to recreate the physiologic responses. They're finding that if for 40 minutes, if you go into 104-degree Fahrenheit hot tub for 6 days, they're finding beneficial physiologic responses to acclimate to hotter environments. And then they're also looking at the military finding different tools to train and figure out how to better monitor this heat response to improve safety for individuals. As we're training someone through this acclimating to a hotter environment, we need to remember that we're really relying on this sweating mechanism, which means they're going to lose a lot more electrolytes initially. So, diet has to be well balanced to not rely on just being thirsty because we know they are sweating, even if it's not visible or they're not perceiving it. We need to make sure that they're well hydrated to trigger that sweating mechanism to dissipate the core temperature heat. And then good news, it is okay to go into the air conditioning afterwards. And our goal is to try and control that CNS drive. Thermal cooling vests are another option. These work through a little bit different mechanism. So instead of training the body ahead of time to be able to function at a hotter environment and still maintain output, this use of cooling vests is saying, well, if the individual is participating, let's say in their sport, and their tissue temperature rises because they have greater metabolic demands, and maybe they're not dissipating it well enough. Well, what if we cool them at, let's say, halftime to lower their temperature of the core back down, and then they can go back to their exercises. So you're kind of counteracting what the CNS would be doing to try and dampen that physiologic response. There are several different types of vests that can be utilized. This is one that might be utilized by workers or the military. On the left-hand side, it's a vest that could be soaked in water because it has a very specific fabric to it. There are others that have little chambers in them that are frozen in order to be cool for hours. In some padding for athletes, when they go in for halftime or when they're out of the participation, they hook them up to a cooling mechanism that pumps the cooling water through the pads in order to decrease their core temperature. Research, of course, looked at, does this actually work? Is it accomplishing what we think we wanted to accomplish? So they looked at athletes and they had them cycle for 30 minutes, then simulated halftime with the cooling vests, and then cycle again. They did find that even though the core temperature and their labs were unchanged, they did have a report of their perceived exertion was better and that their power did increase. So even though it wasn't measurable in the other temperature sense, they did see that preservation of output. The next step was to say, well, okay, what if we pre-cool, like start with the core temperature lower, and then will it allow the individual to function for longer before they exceed their tolerance? What they did find that there weren't really significant changes in the indicators. Skin temperature did go down but there was no significant change in the cardiac strain that had occurred. And just a little note here on the right-hand side, we cannot forget our four-legged workers that are out there. Same thing holds true for them, that they may not be acclimated to the hot temperatures, so they even make those cooling vests for the service animals. Occupational heat stress we need to consider as our patients are not only exercising but also returning to work, that we can see a progression as someone is exposed to heat that they can't tolerate and control their core temperature. It may start as a rash, go to cramps, syncope, rhabdomyolysis, where we start to see that muscle breakdown, heat exhaustion, and potentially heat stroke. If the core temperature is greater than 105 degrees for 30 to 60 minutes, it's said that there's a temporary damage that does occur to the organs. And then by 60 to 90 minutes, unfortunately, permanent damage is occurring, and we don't want to progress that fatal phase. It's important that we look at return to work for our patients. We consider the environments that they're working in. And hot environment does not just mean that they are outside, that the CDC and the National Institute for Occupational Safety and Health, they recommend this as a huge concern. They recognize that there need to be controls in place to avoid this heat stress for workers. In terms of engineering controls, that the air needs to be moving to help with this evaporative cooling of our bodies. The general recommendation for the movement of the air through either fans or an air conditioning type of system is about 300 square feet a minute. There should be shielding, someone working with ovens. If someone's, maybe they're a glass blower or welding, there needs to be that shielding to reflect some of that heat off. That humidity factor, there shouldn't be standing water around that could be evaporating into the air that makes it more humid, that can restrict the person's ability to evaporate. In terms of workplace practices, individuals should be taking their breaks. It's not just for mental or not just physical, it's thinking about that core temperature that impacts their ability to perform. Water stations need to be available. They suggest having a buddy system where one person's monitoring another to see if they're moving into that area of concern. And then, of course, educating individuals and looking at heat acclimatization for employees. That return to work procedure needs to include acclimating to the environment. This may be someone who is working indoors and they have a lot of PPE on for their job. That's not going to allow them to evaporate their cooling as much, and it may increase their core temperature. Maybe they work near equipment that's generating heat, or they are physically outside. There's actually an app that is available for individuals to monitor their heat exposure and temperatures. Their CDC has specific protocols that they suggest for return to work and how someone should acclimate to get back to their activity. That if someone is a new hire, and we see this often when there are changes in the economy, people have to maybe go to more physical jobs from an office job. It's not just learning the skill, it's how can their body react. That a new hire should day one only be working about 20% of the day in that new hotter environment, then progressing it to by day 4, maybe they're finally working a full day, monitoring their exposure. If someone is returning to work after being out, let's say for a workers' comp injury or other reason, they need to reacclimate to that environment. Consider public health resources and education. We all know not to leave someone in a hot car, that exponentially the temperature increases. Do we know that everyone translates that to mean when your significant other picks you up from the hospital and you stay in the car while they run in to pick up your prescription, you could be increasing your heat exposure? Or that caregiver that brings someone in for their therapy appointment and they remain out in the hot car, well, are they at risk? Lots of different ways, and there are many infographics and resources available for the CDC to educate on this, and I include links to those at the ends of the course notes packet. Whole body heat stress is using this exposure to heat in a little bit different way. And now is where we're getting into where the research is really heading. That the thought is, if we know exposing individuals to heat causes all of these physiologic changes, alter cardiovascular response, is there a way to flip that and say, well, what about someone who can't exercise? Could we potentially have them go into a sauna, either a traditional sauna or maybe an infrared one, and stimulate their body systems, stimulate their arteries, the oxidative stress, the circulation, to replicate exercise without them actually having to go through the process of exercising? So, is there a way to use passive heat exposure to the whole body to induce the same physiologic effects associated with exercise? And they're looking at this for cardiovascular conditions and other chronic conditions. So, my thought is, at some point, are we going to be able to have our insurance cover putting a sauna in our house as DMA? I'm making a little joke about it, but I just always find it fascinating when we look at all the different ways that the research can be utilized and the innovations that are coming. When we look at physiologic responses to passive heat application, so going in a steam or a sauna, it affects many body systems. And if it's in a controlled manner, it can really have positive effects. Think of someone who has a spinal cord injury that they can't physically exercise. So they're at increased risk of cardiometabolic disease. There was a study that looked at individuals in Finland where apparently I need to look at moving because it is very common, at least 4 to maybe even 7 days a week, to go to a steam room or a sauna and relax. There was a long-term study where they looked at individuals who started out between 42 and 60 years old, and they followed these 1,600 individuals for 24 years. And they looked at the development of different diseases. They went back, they looked at their medical and their lab records. And what they found is they had lower blood pressure, increased cardiac output in those individuals who routinely visited the steam rooms, lower cortisol levels. Looking at different biomarkers, they had improved glucose metabolism, decreased insulin resistance, and those heat shock proteins that are so important for repair and healing and transport of different proteins, they had elevated levels of those biomarkers. So there's looking at all of these significant benefits that led to a lower development of chronic diseases for individuals. Some other studies looked at just going in a sauna for 5 to 20 minutes, 2 to 3 times a week, contributing to some of these also improved functions. Of course, I said, okay, that's all great, but let's look at some patients who have pathology. Let's look at some specific conditions. Does that heat exposure, play out to actual benefits? One particular study looked at individuals with congestive heart failure. They were adults. And they had the individuals use a sauna for 2 weeks. It was 149 patients, so a reasonably good sized cohort. And function wise, they had an improved 6-minute walk test. And then what was really beneficial is when they looked at imaging, the cardiothoracic index ratio improved for those patients, that the heart size actually decreased. And we know that when CHF is present, there's that hypertrophy of the heart. That it actually, the ratio improved, showing that they actually had a decrease in CHF classification. Get your tissues out for this next one. Looking at pediatric patients who had ventriculoseptal defects, there were 12 infants where they were taken into a sauna for just 5 minutes each day over a 4-week period, and 7 of the 12 babies did not need surgery to correct the defect, that their ratios improved, the defect shrank, and they didn't even need surgery. They're also showing positive benefits for decreasing PVCs. Individuals with ischemic heart disease, what they found is that when they took individuals who they didn't have other surgical options, they had exhausted all the potential ways to manage their ischemic heart disease, and they had them go into the saunas over a prolonged period of time, and they found that they had improved defect reversibility. So that means looking at the occlusion of the vessels that occurred and the reversibility of that, the ability to improve the blood flow in the area, that it did have positive benefits for them. How about metabolic outcomes? As we look at individuals who are presenting with impaired glucose metabolism due to diabetes or obesity, there was a small cohort study in 2018 that they looked at the fasting insulin and glucose levels for individuals. They had them go into a 39 degrees Celsius water immersion, 1 hour a day over a 2-week time period. And then they tracked the venous blood. And what they found is improved modulators of inflammation with the anti-inflammatory cytokines, those constituents that increase glucose uptake were more bioavailable for them. So they're finding that there was improved glucose metabolism, that there was improved cardiovascular health for the individuals. And this is showing some progress, that you take someone who can't actually perform exercise, that initially, at least until they can, we can induce these changes through different ways with exposure to heat. Peripheral arterial disease. This is occurring in individuals who have decrease in that lumen size in the lower extremity vasculature. We see that this decrease in the lumen size, if this is going down to the leg, as the individual is ambulating and there's increased demands of the tissues, oxygen and nutrients needed of those muscles in the lower extremity. As the circulation tries to go through this restricted vessel, they're going to experience intermittent claudication, decreased muscle power, pain, and decreased walking distance, decreased function. What they know about peripheral arterial disease is that there's some inflammation, there's that arterial obstruction, and there's an impaired ability of the circulatory system to kind of do more collateral circulation or angiogenesis, new blood vessels, to make up for those that are impaired. And as they look at this heat stress and exposing the whole body to it, the discussion in the research is, well, would it work for this population of patients? Could we change the diameter of that vessel by having them increase their core temperature and by their being warmer? And then, in effect, carry that out and say, well, okay, if we're improving the functioning of these vessels, then can we improve their overall cardiovascular health and help decrease the mortality and morbidity from the peripheral arterial disease? The reason that exposure to heat versus actual exercising is extra appealing for this population is because exercise increases the metabolic demand. There's a greater need for that muscles to have delivery of oxygen and nutrients. Whereas passive heat exposure is not increasing that demand. So it's like you get the benefits without the extra work required of those vessels. That's the theory. Where the research is going, looking at these specific outcomes, is also promising. That they're analyzing limb perfusion in individuals that are exposed to several different types of heat. You might already be thinking that, well, individuals with peripheral arterial disease, they may also have other concerns, that too much exposure to heat could be detrimental. So what they looked at, one example was utilizing a sauna, where they had the individuals go into the sauna and then they analyzed not only the 6-minute walk test, which is a functional indicator, visual analog scale, looking at their claudication, all of those things improved, which is great. It's very functional. As clinicians, we clearly see that benefit. They also looked at more objective measures from a physiologic standpoint. They used angiography and they saw actually a visible increase in the collateral vessels after 10 weeks. Lower limb heat immersion was another option in a different study where they immersed those limbs. They found that there was a significant increase in heart rate for the individuals. So we're getting some systemic benefits, decreased blood pressure that shows that the cardiovascular strain was decreased for them. Hemoglobin levels were increased, as well as perfusion to the actual limb. And they saw all this with only a 1-degree increase in core temperature. So we weren't getting into that area of concern with increasing core temperature too much. Another study looked at putting a garment around the limb that just circulated warm water for them. It was at, I think, 48 degrees Celsius for about 90 minutes. And they did find, when they looked at MRI and the popliteal artery, they looked at the velocity of the blood flow also going through it, and they found that there was a 68% increase in velocity. Again, an indicator that we're actually getting improved circulation, and the endothelin 1 concentration decreased. That's a vasoconstrictor. So the fact that there was less of that, again, they attach that to improving that circulation to the area. So we're looking at benefits as an opportunity here to improve hemodynamic response in those peripheral arterial disease patients through these different mechanisms of passive heat exposure. patients who have glucocorticoid-induced myopathy. They might be someone who has Cushing disease, rheumatoid arthritis, different conditions where those long-term use of steroids is needed to manage their chronic inflammatory condition. Unfortunately, this leads to muscle atrophy. So the myopathy that results is a concern. In animal studies, what they did was they induced atrophy in tissue of animal, and then they took that and they heated it up to see what the response was as they applied direct heat to those atrophied tissues. And what the Journal of Cellular Physiology found in this study is that the skeletal muscle changes that occurred contributed to increased fiber diameter. They had improved capillaries, better heat shock proteins, which we know are important to rebuild that muscle, particularly in individuals where they have atrophy of those fast twitch fibers. They did find more of a response in those proteins to help regenerate those muscle cells. So this is early on, but they particularly think it might be promising because when patients have the muscle atrophy because of the long-term steroid medication use, it does tend to be those fast twitch fibers that atrophy more quickly, and they seem to be more responsive to the heat. So this is still emerging. If we look at bruising, individuals who utilize low molecular weight heparin injections into the abdominal region to prevent venothrombus embolism, they need to have these injections in that region for that subcutaneous fat to slowly absorb and distribute that for the physiologic benefits. However, the concern is that the patients, they endure significant bruising. It's a lot of discomfort. It doesn't look good. So there's always a challenge with compliance for patient, contributes to altered body image. So where do they find another injection site that would be comfortable for them? And there is some evidence that utilizing a local heat application can be beneficial with the vasodilation, increasing the cellular metabolism in the area to help stimulate that tissue recovery, to remove that buildup of the cells in red blood cells in the area, and help alleviate some of that bruising. The concern is we have to really coordinate this with the physician and make sure the patient is not doing this on their own, because it can alter the absorption rate, which could have a more significant consequence for them than just the bruising. Looking at if you're working with individuals with dysmenorrhea, if you're in women's health or you're working with younger patients in their teenage years, they say that there's a culture of science related to dysmenorrhea and the pain that occurs with the menses. If you think this is something that needs to be addressed with the population you're working with, there is a menstrual distress questionnaire that is a way that you can gather the information without having to have that specific conversation. What they are finding in the research is that when someone has primary dysmenorrhea that is leading up to the menses and early on in the cycle, that there are a lot of prostaglandins in there and they start to diminish and then the pain subsides. Well, in the interim, they're finding, particularly in these patients, that the application of heat over that abdominal area, it seems to help with the blood flow in the circulation in the area, that it is beneficial in decreasing the tension in those abdominal muscles that just occurs because of the pain that the individual is having. It increases in pelvic circulation, and it seems to be beneficial in decreasing some of the swelling and congestion in the area that can help alleviate some of the pain and discomfort. If you work with individuals in an area that might be a little cooler, you might have patients who are exposed to extreme cold that leads to hypothermia if they're participating in wilderness and different outdoor adventures and type activities. When they look at preserving the person's life, they need to rewarm their system. The concern is if they warm someone up too fast, it could put a lot of cardiovascular strain on them, increase that workload and demands, and could potentially compromise their life. So, what they're looking at is many different ways in the research to slowly bring that temperature up. And it fit this topic because they used fluidotherapy, so I wanted to share it. They took individuals where they induced hypothermia in a safe way, and they suspended them with all four extremities in fluidotherapy and tried to slowly increase the core temperature for them. They did find that it wasn't as beneficial as water immersion. However, the thought was that the desensitization that occurs from the fluidotherapy combined with the slow increase in temperature might be another option to help these patients that are recovering following hypothermia. I just thought that was an interesting use of a modality that we employ in a completely different way. As we look at sleep quality, we know that sleep is so important for so many different body functions, and unfortunately, it's disrupted in many individuals, particularly in our older populations that we work with. We know that they have decrease in muscle mass, decrease in metabolism. This leads to decreased thermoregulation as we age, and that tends to lead to poorer sleep quality. Research is starting to find that there seems to be an overlap in our nervous system, that there's some redundancy in neurons that sense heat, sense temperature, and those that begin to fire their pattern right before we start to go to sleep. And they're looking at the fact that, well, if these heat neurons and sleep neurons replicate some redundant pathways, can we tap into the heating in order to improve sleep? And several different studies actually looked at that. One of them had nursing home residents where they wrapped the lower extremities in hot packs before they went to bed. They wrapped the anterior leg, the bottom of the foot, the posterior calf region, and they applied this for 40 minutes before they went to bed for 8 weeks. They found decreased episodes of waking. There was better periods of long sleep, decreased latency. That means they fell asleep faster. So they fell asleep faster, stayed asleep longer. So there was better sleep efficiency for these individuals. And then in another study, they actually took patients who were on hemodialysis, and they used bilateral foot baths for about 30 to 40 minutes for 4 weeks. And they again found that they were more awake during the day and more functional. They had better sleep that was objectively measured on the Pittsburgh Sleep Quality Index. And then in addition, their dialysis symptom assessment had decreased scores. So it really seemed to carry over into better daytime functioning. Another way that we might be seeing heat applied differently, and I know there's a commercial out there now of a bed that somehow heats where your feet are. A simpler way might be to consider maybe just wearing fuzzy socks to bed, assuming we don't have any concerns about them getting too tight or other issues. It might be something to consider, or additional blanket over the foot of the bed if that warms the feet a little, as long as it's not contributing to too much foot drop. Different ways that we can think about a lot of things we discussed today. At this point, my hope is that you're still awake like this guy, and I haven't put you out like this little lady over here. Today, we took some time and we discussed our traditional applications of heat. We also looked at some more innovative ways that thermoregulation is being utilized to address different chronic diseases, and some emerging techniques that you might start seeing in the research to incorporate into your practice to assist your patients in improving their functional goals. So according to the research, ultrasound has no benefits. This is always a big debate, and it seems to change over time. Currently, the research is leaning towards the fact that the micromassage and all those non thermal effects of ultrasound that were historically thought to be occurring in the soft tissues are not really happening. Or if they are, they're not happening to a point where they're able to have any significant effect for a change in objective measures that actually contribute to improvements in function. This means that it's not supported by research to use ultrasound to reduce swelling, promote joint healing, or achieve any long term pain relief for musculoskeletal conditions. That's where the research stands right now. Where it seems that there might be some benefit that can be identified in animal research as well as some human research is that there might be benefits related to deep heating. The research emphasizes that if you are using ultrasound for deep heating, that you have to consider many different factors because there's a lot of attenuation as the sound waves are traveling through the different layers of the tissue. So even if you set the frequency correctly for the depth of penetration, there's still attenuation and some loss of energy as those waves are being transmitted. So it's also the heat will be dissipated by the vasculature, the thermal conductivity of various types of tissues is going to be different, and all of this together can influence the amount of heat that's actually generated at the target region. The research says that we need to be sure that all of our parameters, not just frequency, but also looking at intensity and time, are appropriately set to achieve a tissue temperature rise to obtain any benefits. Even with all that, it's still debatable in the research whether the heating that does occur actually correlates to any significant viscoelastic changes in those tissues that are necessary for muscle length gains as well as for gaining of pain. What is the general age range for the epiphyseal plate growth to be complete in males versus females? This is actually difficult to pinpoint. There are several factors that come into play, including genetics, nutrition, hormone levels. All these different things are going to influence the fusion process of those growth plates. Some references say that the long bones of the body stop growing at around age 18 in females and age 21 in males. But then when you look at other studies, they say, well, for males, it might actually be up to age 25. Some other sources are on the lower end, that they're saying more between the ages of 14 to 16 in females and 16 to 18 in males, where we see closure of those growth plates. What is consistent in the research that I looked at is that at any particular age, females tend to have a more advanced bone age compared to males. And then also looking at skeletal maturation overall, that process, looking at all the bones in the body, that they're finding the whole process seems to last longer in males, where they're having closure of those growth plates at a later age than females. It was also interesting to note when I was reading different sources that when they look at different bones, and let's say we're thinking a femur, that it is going to close at a certain age. Well, we have growth plates on both ends of our bone, and they're finding that both the proximal and the distal ends of the bone don't have closure of the growth plates at the exact same moment in time, that they may actually ossify at different ages, and the amount of time where that ossification is occurring can be several years, even within the one same bone. So what do we take from this to answer your question? I can't give one specific age, but this is just some of the information that is available. And the only true way to know if the growth plate has closed is through radiologic examination. Is a diagnosis of cancer a blanket contraindication for the use of heat? No, I wouldn't say it's necessarily a blanket contraindication to the use of heat based on the current research that I looked at. It's a diagnosis where we need to gather more information on each specific patient as an individual, and we need to be more inclusive in our assessments before we're applying heat. For example, someone who has a past history of cancer, we need to make sure that the new diagnosis we're seeing them for, or if it's direct access, the painful condition that they may be coming in reporting, we need to make sure that it's not potentially a metastasis of their previous cancer. Then, when we look at individuals who have a current diagnosis of cancer, particularly if it's in the early stages, the risk benefit analysis has to be considered to avoid potentially contributing to metastasis. If someone's in the later stages and the condition is determined to be life limiting, then there may be more of a benefit for the utilization of heat to alleviate pain in particular, where we're looking at more palliative care and trying to improve comfort for the individual. That risk benefit analysis may lean more towards there are more benefits for the individual at those later stages versus the risks of spreading that cancer. While it may hold some of those risks of metastasis through the application of heat, it may also allow the patient to reduce their use of narcotic pain medications that could improve the quality of the life that they have left in terms of their cognition and comfort, limiting side effects from those narcotics. Those are all things that will go into the discussion as to whether or not heat can safely be utilized in someone with cancer. It would definitely involve discussion with the patient if they're capable, or family member, as well as the physician. And I would also maintain thorough documentation so that we have a record of that decision making process and consent to it. Please address the use of heat versus cold for a hematoma. First, let's take a moment to distinguish bruise from hematoma. And this is something we all know, that a bruise or ecchymosis is occurring following some type of soft tissue trauma. It occurs with minimal force when someone has a bleeding disorder, thrombocytopenia, or is taking blood thinners. Uh, there are typically an association between bruising and some type of trauma to the tissues. It's not just happening spontaneously, even though it may in some of those situations occur with less force. What happens, we know, is that those small vessels are damaged. It's going to disrupt the integrity of that vessel wall, allowing the blood to leak into the skin and fatty tissue directly under the skin. And that's that black and blue discoloration we see, are those old blood cells trapped in the area. If we look at bruising and the research on it, I did find several studies that examined bruising associated with injection of low molecular weight heparin. And both heat and cold have been found to help manage the pain associated with those injections, as well as the amount of bruising following the injection. Cold accomplishes this through vasoconstriction to reduce the actual formation of the bruising, and then heat more through the vasodilation and increased cellular metabolism to clear out the blood cells from the area. Your question is about hematoma, which is more severe bruising following trauma, and it's associated also with surgical incision sites for example. It's a collection of blood, but this is occurring outside the blood vessels, and it presents as a more painful area, usually with more of a palpable mass in the area. It has that focal swelling and becomes more taut then on the skin and surrounding tissues as that blood is confined and it can't be moved out of the area. That's what's creating that pain that the patient is usually feeling. I didn't come across any specific studies that looked at heat versus cold for hematoma, but I did find consistency among different physician protocols on how to manage it. Typically, the recommendation was for what we would expect, that cold within those first 48 hours, and then followed by the application of heat after that time period. Since patients with diabetic peripheral neuropathy usually have impaired sensation in the lower legs, wouldn't the capsaicin patch be contraindicated? I love that you're thinking about contraindications. What we need to remember, though, is that capsaicin is going to induce the perception of burning in the area where there's either the topical application of the ointment or gel or where the patch is applied. Um, it's not in response to actual heating of the tissues and tissue temperature rise. So that burning, even though it's perceived as something similar to when there's a tissue temperature rise, that's not what's happening. That burning sensation is the result of the mechanism of action of that capsaicin on the nerves, and that ultimately is going to lead to the alleviation of their pain, where those nerve receptors are stimulated and there's some change in them, where there's either cellular apoptosis, so death of those nerve conducting cells for short term before they regenerate again, that are leading to that limitation of the perception of pain. Because that's the mechanism of action, we're not actually relying on the patient's perception of heat, like a hot pack, to avoid burning or damaging the tissues. That's why it's not contraindicated in those patients with the diabetic peripheral neuropathy. It's actually recommended, and the research is showing that it can be beneficial to utilize the patch to alleviate that particular type of pain. Now, when we do look at patients who are using the capsaicin patch who have impaired sensation, we do need to make sure that they are educated appropriately on the potential side effects of that patch so that they don't have other compromise that results or other complications. This includes that we want to make sure they know to wear sunscreen, because they're going to be more sensitive to heating in the area where the patch or the cream is when there's a concurrent heat application. So we want to try and protect that area or make sure that it's covered from that sun exposure. That we want to make sure they're inspecting their skin frequently, because the application, particularly of the patch, because the potency is greater, there can be some additional skin irritation that occurs that they may have to visually inspect for. So if they're also visually monitoring their skin for the development of any hives. If hives are developing, they're likely perceiving some level of itching in the area. If it's also associated with swelling, throat irritation, respiratory compromise, this may be indicative of a potential allergic reaction.